Welcome to everyone who has joined us. Happy first week of World Asthma Awareness Month, May 2018. My name is Sheila Brown, and I am with the United States Environmental Protection Agency, the Office of Air and Radiation, the Asthma Program. Today, the Environmental Protection Agency is pleased to host this important and exciting webinar presentation and discussion forum on exploring pathways to reimbursement for in-home asthma interventions. There is strong evidence-based science that proves the link between asthma and indoor environmental exposures. Because of this, EPA has for many years been a committed champion for expanding delivery and sustainability of in-home asthma, environmental care, and interventions. We are so pleased to be able to offer today's webinar to hear from three innovators from three different states, Rhode Island, Missouri, and Maryland, who have found solutions to ensure that children who most need in-home environmental asthma care and interventions can receive these services. We are eager to learn from, to support, and to shine a spotlight on these state stories that can teach us all so much more about how to convince critical partners that improved asthma care is possible and how to move whole systems to bring the best care we can to the people, especially children who most need high-value, quality, comprehensive in-home asthma care and interventions. Before I turn the call over to the moderator, let's review the process for the discussion forum. We are certain that some of you will have aha moments, questions, comments, suggestions, topics for further discussion, and perhaps future webinars that you will be anxious to share with us. To make this happen, we will host an Asthma Community Network discussion forum immediately following the presentation. Here's what you need to do to join the conversation. If you are a network member, log into your AsthmaCommunityNetwork.org account. If you're not a member, we need to change that, and we can change that quickly. Create an account at AsthmaCommunityNetwork.org by clicking the Join Now link at the top of the page. Your account will be approved instantaneously, and you can begin posting questions. Then click on the discussion forum button on the home page. Click on the live online Q&A webinar link for today. Click on the Post to the Forum link to post your question. And most importantly, enter your question, comments, suggestions, and click the Save button at the bottom of the page. I'm going to turn the microphone over now to our moderator, Kate Hastings of the Scientific Consulting Group. Some of you may know Kate. She has been a contractor and partner to EPA and other government agencies for more than 20 years. Kate works with communities across the country to assist with and to facilitate system changes to improve population health outputs and health outcomes. She is very experienced in moderating conversations about improving asthma care. Please join me in a warm welcome for Kate Hastings.
Thank you, Sheila, and thank you to everyone who has joined this exciting and important call today. I want to get us right into the meat of why we're here. What we're going to do together today is look nationwide so that we can all see what are the beginnings of real transformations. We are seeing across the country innovators finding new ways to pay for new kinds of care delivered in new places so that we can all address population health, disease disparities, high utilizers, and the other topics that are facing all of us that we need to find solutions to, and that in-home asthma care is an example of. You're going to hear today about three innovators who, with teams of people that they've drawn to themselves, have worked in states to find mechanisms and pathways to get paid so that we can deliver great asthma care at home. You're going to hear how they have taken what for them may feel often like one step forward and two steps back, but that when we all listen and see the many ways states are finding to get great care at home, you'll see there is a system change happening. One thing I like to remind these leaders that I'm so lucky to get to talk to frequently is that whole system transformation and change, what they're doing, it's not about moving one person 1,000 feet. It's about moving 1,000 people 1,000 feet, one step at a time. And today you're going to hear how that is happening in different states with different pathways, but that we are moving toward Medicaid reimbursement for in-home environmental asthma care. So across the country, we are seeing the Centers for Medicaid and Medicare Services and state Medicaid programs and managed care organizations increasingly finding solutions to direct health care dollars to in-home asthma care that includes environmental interventions. And we're seeing this funding starting to flow to a mix of licensed, unlicensed, certified, and sometimes uncertified home visiting professionals. We're going to hear today about 3 local efforts, and they're all at somewhat different stages of implementation, and they're each using different mechanisms to pursue payment, and you'll hear that the reason they're pursuing those different mechanisms is because they paid attention to their own local landscape. But as you listen across these stories, consider, why did each state follow the path that it did? What major obstacles do you hear in these stories, and what common solutions can you hear that they found? And what do these 3 speakers and the partners who they describe working with, what do they tell you about what it takes to lead this kind of change in your own state? Now first, let's hear from Julian Rodriguez-Drix. And as you listen to Julian today, I would suggest you particularly listen for the language that Julian and his partners developed to convey to both CMS, the Centers for Medicaid and Medicare Services, and to their healthcare system locally, what they were trying to do and why. How they used the language of targeted, evidence-based services for high utilizers, and the idea of preventing healthcare costs to convey what they were trying to achieve. Also listen for how Julian and his colleagues developed partnerships across policy and political domains, so they were able to track the changing landscape in Rhode Island and stay with it to achieve their goals. Julian, would you please take, say, 12, 15 minutes and talk to us about Rhode Island's story?
Definitely. Thank you for that introduction. Hello, everyone, and happy Asthma Awareness Month. It's my pleasure to be here with you today to be talking about the state of reimbursement in Rhode Island for asthma home visiting. As a disclaimer before I start, we are not there yet. It's been a long and winding path. We've had some very exciting moments. We thought we had our champagne celebration moment with Rhode Island statewide Medicaid agreeing to cover asthma home visiting statewide using EPSDT, the early prevention screening detection mechanism within Medicaid. But it didn't, unfortunately, make it through the state legislature's budget process, not about the content of what we were doing, but about some of the procedural pieces in the timeline. So we've made progress. It's been a winding path. We've learned a lot of valuable lessons along the way. And although we are not there at the finish line yet, I'm happy to share what we've learned, and I hope that it'll be of value to you all. And one of the biggest things we've learned is that success is not a simple yes or no or a black-white picture. There's no finish line that you've crossed it. It's a series of steps, and each one of them can be considered a success. And through this process, we do have a significant infrastructure built up in the state for providing asthma home interventions. We have a managed care organization that, through our partnership, is now sending community health workers into the home. And we have had a lot of other successes, but we also have further to go. So I'll start by briefly giving an explanation of the context and where we started. Next slide, please. So I wanted to start with this map of Rhode Island, and on the right, a map of our core cities, looking at asthma and the context of poverty and housing in Rhode Island. This is important context to remember. Asthma, while it's our focus, is just the symptom. Poverty, racism, environmental conditions, what we know and refer to as the social, economic, and environmental determinants of health, are truly the problems that we're seeking to address that are underlying these symptoms. My personal background is as an environmental justice community organizer for a number of years, led me into my work in public health, and my current role as the asthma program manager of the state. And I do believe that those skills of community organizing and advocacy have been valuable in translating to helping to navigate this complicated landscape. It takes advocacy, dedication, strong partnerships, strategic thinking, adaptability, and sometimes the willingness to take risks to pursue the goal of seeking reimbursement for home visiting. These maps that we're looking at here today paint the picture of the context for asthma in Rhode Island. We have strong disparities, geographic disparities, racial disparities, economic disparities, age disparities for the burden of asthma in Rhode Island. On the left, you can see statewide. This is based on claims data, a report from 2014 that we produced. You can see the areas that are shaded with poverty, with childhood poverty levels of 25% or more is how we define our core cities. And we see that the asthma burden very much concentrates, for the most part, within these areas of the highest poverty levels. We have a very big range of asthma prevalence across the state, and here we're defining prevalence based on asthma claims. So which people have filed an asthma claim within the period we were looking at, with it being much higher in our core city high poverty areas. On the right, we're zooming into those core city areas, and we can see that there's those disparities even within the core cities. Which also maps on to the areas of poverty. And housing is a very strong factor in determining this. So you can see the chloropleth maps, the density maps of looking at where these asthma claims were located, and how closely it lines with areas of public housing authority buildings and other low and moderate income affordable housing. So we know that housing is a key factor that we need to address in looking at how to address asthma in our state. Next slide, please. Our primary program for home visiting is the Home Asthma Response Program, what we refer to as HARP. It's an evidence-based intervention that is targeted for high-risk, high utilizers, pediatric patients who've had multiple emergency department visits or hospitalizations. The components of the program include intensive asthma self-management education, which is delivered by a certified asthma educator with clinical expertise in the home environment. The certified asthma educator covers asthma knowledge, understanding of the disease, the symptoms, the medications, how to properly take the medications, understanding your triggers, asthma action plans, the core components of guidelines-based care of intensive self-management education. We also have a community health worker who attends with the certified asthma educator, and the community health worker conducts a detailed in-home assessment, room by room, identifying all of the asthma triggers in the home. And then the community health worker returns for 2 following visits, bringing environmental supplies and providing reinforcing education around asthma, the symptoms, the triggers, and what can be done to control asthma by managing the triggers. The environmental supplies include a HEPA filtered vacuum cleaner, mattress covers, cleaning supplies, pest management supplies, and the community health worker provides instruction on how to use them effectively to address asthma triggers in the home environment. One thing that the HARP program does not address that we do recognize as a need and are working on other ways of addressing is the environmental remediation. Sometimes there are things that are beyond what a tenant or family can do for themselves that require structural changes to the house. So we have a separate program that is closely connected that involves a code referral from a medical provider to code enforcement to be able to make sure that landlords are keeping houses up to minimum housing codes. and we have strong partnerships with other housing providers who can provide, when funding is available, remediation services, and we're exploring possibilities through mechanisms such as Pay for Success to see if there's ways of finding additional funding to be able to do home renovations. But we do want to say that it's very important, and we really emphasize the importance of these environmental supplies as being a core part of providing home-based asthma interventions. Next slide. We've done this over a number of years with many partners. Our core partners in terms of delivering the intervention have been Hasbro Children's Hospital, the largest pediatric hospital in the state of Rhode Island, and St. Joseph's Health Center, a community-based health center that also has a lead center. And so the connections between lead and asthma and healthy housing are very clear with that. We started the intervention in 2011, and we've gained a lot of national support, and we're very grateful for the national efforts around asthma home visiting. Our intervention was combined and aligned with a similar model in Massachusetts and was replicated across 4 different states and 9 different provider sites as part of a CMS Innovation Center award to Health Resources in Action. That was a really key stage in expanding the intervention that had gone through a successful pilot phase through CDC funding initially, and getting funding to expand it and evaluate it, collect claims data, and really develop the model. Following that, we were invited to participate in the 618 initiative, which if you're not familiar with it, I highly recommend going to CDC and looking up 618. And it's an initiative that has been bringing together state public health and state Medicaid to be able to look at 6 high-burden health conditions that are associated with 18 evidence-based interventions with a significant evidence base that they can both improve health and save money. And that's been a very key support of ongoing technical assistance over the past 2 years, supporting the work that we're doing. We've also worked with the Green and Healthy Homes Initiative nationally and the state, the local chapter in the state, looking at home renovations, Pay for Success feasibility study, and most recently through an EPA-funded initiative, working with one specific organization that I'll speak to in a little bit, an accountable care organization in Rhode Island. Through these partnerships, we've been able to continue to build on the work that we've been doing, gaining additional funding and/or technical assistance, and help to continually build our business case, showing the impacts and the effectiveness of the programs that we're doing. There's an incredible value to the technical assistance, helping us learn how to effectively frame the intervention and its impacts. We've learned that when communicating about our interventions, although we have reams upon reams of data and evidence showing its effectiveness, when speaking with decision makers, less can be more. Boiling it down to concise talking points has been a really key lesson learned, and the framing of those talking points is also key. We've learned to frame it as a targeted healthcare intervention that needs to occur in a home-based setting based on the nature of the disease of asthma that is so susceptible to environmental triggers, instead of framing it as a home visiting program that is a type that happens to focus on asthma. Framing it in that way makes it fit better within the healthcare system. We've also learned to approach this as a partnership with healthcare payers of how to help them reduce their costs and improve their quality, rather than saying, we have this amazing program that we've been paying for through grants, and we want you to pick up the tab for it now. That approach has not been effective, and it's important to work in partnership with healthcare payers, especially with state Medicaid and managed care organizations. Next slide. Through our 618 collaborative with Medicaid, we've been working in partnership for 2 years, and we've had many successes, one of the largest ones being collaboration around data analysis. Through our 618 partnership, at the leadership level of having our leadership in public health communicating with Medicaid's leadership, as well as program to program, we have gotten approval through the IRB and through executive authority, state agency to state agency, to have access to the entire Medicaid pediatric database of claims and eligibility data starting from 2013 onward, and we're continuing to get data from them. It's individual identifiable data down to the address level, which allows us to map asthma claims. It allows us to evaluate our intervention. It allows us to understand who would be eligible for what we are proposing in HARP. From our previous evaluation of the HARP initiative, we've learned that it's most effective and we see the strongest return on investment when we target it at the highest utilizers. So setting the eligibility has been very key, and defining HARP eligibility as 2 or more asthma-specific ER visits or 1 or more inpatient hospitalizations within the prior year. When we define HARP eligibility based on that, we can then look at this Medicaid data set to see who would be eligible, how many children are we speaking of, and how much would it cost to provide the intervention to them, and what are the existing costs that these children are costing Medicaid and the managed care organizations. So as you can see from the chart here, we were able to identify that in fiscal year 14 and fiscal year 15, and we're continuing this analysis for more recent fiscal years, it's not a huge number of children who would be HARP eligible within Medicaid. The N is between 300, 400, the highest we've gotten is 497 in fiscal year 15. But when you look at the cost, the total annual cost of those patients, they are much higher than the general average pediatric Medicaid participant, and much higher than those who have asthma within Medicaid. So we're really talking about a targeted intervention at high cost, high utilizers, and are offering an effective solution for being able to bring those costs down and achieve asthma control. We can also see that it's a very targeted location in terms of geographically, which makes sense given what we know about asthma disparities in the state. But this also shows where the intervention would need to be delivered and which partners are effective at reaching this population and being able to deliver the intervention effectively. Next slide. This is an example of how we have combined this data, boiled it down to a single one-page sheet of the Home Asthma Response Program, summarizing what the intervention is, what the impacts of it have been, and who would be eligible for it, and what types of outcomes we've seen. So in the red bars in the middle, you can see our initial return on investment analysis, and we are continuing to do further analysis on this with the new Medicaid data set that we have. But within this, we were able to see consistent reductions in emergency department visits and hospitalizations, with larger reductions, both in terms of percent and total amount of the reductions, when we're looking at those high utilizers. This is part of the evidence we use to really target the intervention and say how eligibility guidelines should be set. We've also shown improvement in asthma control levels, as well as important quality measures that matter a lot to the healthcare system, such as the HEDIS measure for asthma medication ratio, a measure which is traditionally very difficult to move and a very low measure, measuring the ratio between controller and rescue medications. And we were successfully able to remove that measure from 32% attainment to 46% attainment, which is a phenomenal result, and something that, in addition to the financial improvements and the cost savings, is something that the health insurance plans care a lot about. Through this process, we've earned support from Rhode Island Medicaid. We've built strong partnerships, and we have ongoing data analysis and sharing, and we're exploring new policy options for coverage. So we didn't initially look at EPSDT, but the suggestion of Rhode Island Medicaid was that that would be the best way to be able to provide this intervention as an already covered benefit that already fits within what the state is doing. We have a lot of initiatives across the state already around preventive care, around community health workers, and this fits in an important way in terms of building off from that. In terms of our next steps, since we do have the active support of Rhode Island Medicaid, we are now bringing this data and working directly with the managed care organizations of how to fit HARP into their own specific structure. Rhode Island is predominantly a managed care state. It's quickly becoming almost 100% Medicaid managed care in terms of the Medicaid population. We're focusing on Medicaid because we know that this is where the largest burden is, but we have also been speaking with commercial insurers, and there's a lot of interest for HARP there as well. We are also now working with accountable care organizations, recently emerging ACOs, which in Rhode Island we call accountable entities, or AEs. And very recently, we are working closely with one of the more well-established AEs in our state, Integra, which has an EPA-funded technical assistance grant with the Green and Healthy Homes Initiative, specifically around finding solutions, and the deliverable at the end of the grant will be working to achieve reimbursement and coverage of integrating HARP within Integra's delivery system, and working with the managed care organizations that Integra has contracts with to pay for that service. And we really think that the accountable entities are an excellent mechanism in ensuring that the HARP intervention is even further connected to primary care and the connection between providers and payers in the state as part of our overall state's efforts around not just improving asthma outcomes, but improving care and transforming the healthcare system across the state. I'll stop there, and I look forward for discussions in the forum and from hearing from my fellow panelists. Thank you very much.
Thank you very much, Julian. That was great. We really appreciate you and your time and your story. And in the interest of time, I'm going to move us on. Would you please advance the slide for me? Now we're going to hear from Eric Armbrecht from Missouri, and I love the Show Me States, Show Me Reimbursement title. I hope everybody notices. In Eric's story and in the story of the partnership in Missouri that has worked so hard to expand reimbursement for in-home asthma interventions, I encourage you to listen specifically for what the leadership team in Missouri learned about how their state was interested in advancing expanded asthma care or expanded reimbursement, how the Medicaid program thought through the decision, and what key points were in getting to yes, and also listen for what the leadership team has learned somewhat the hard way about what it takes to streamline actually getting payment from the healthcare system to the field. And you've got a great story coming here with Eric. I'll turn it over to you, Eric, and you have about 12 minutes.
Great. Thank you very much. Can you hear me okay?
We can. Thanks, Eric.
Great.
Take it away.
All right. Next slide, please. So this is a little dense in terms of text, but it'll keep me on point, and I was asked to do that. So we learned a lot on our bumpy, curvy road to reimbursement for asthma care support services. And I use that term a bit more broadly than just in-home or home environment services, because we have felt like reimbursement for self-management education services in a clinic setting are probably just as important and equally kind of a gap in when you look at coverage benefits in our state. So point number one is that a state plan amendment for us was really a starting line. So like Julian said, like you sort of think, hey, we've arrived when you do all this work, but really all you did was get yourself to a starting line in terms of getting funds to flow into provider organizations, whether that's community health workers or FQHCs or public health departments who can provide in-home assessments or other types of services. So in getting to a state plan amendment, state-specific data helped Missouri HealthNet, MoHealthNet is the name of our Medicaid plan, pursue the SPA. So it's filed, it's filed on behalf, or it's filed by Medicaid. It's not something you can just file on your own. And so working with your Medicaid program in partnership and giving them what they need to write a compelling state plan amendment, or at least to write one in a way that is compelling to them to approve, to submit, is important. If you're pursuing this particular option, which is one of a number that you could consider, but be patient, they take time, and give yourself, I'd say, an 18-month course of action to advance this option. This is not a 6-month project, to go from concept to an SPA filed. The other thing, my other piece of advice around a state plan amendment is take what you can get. Don't be greedy or overly prescriptive in the state plan amendment. It turns out that some wiggle room later might be very helpful. There was some tension or debate, or what do you want to call it, about how particular we needed the state plan amendment to be, or how particular we needed the rules that followed the state plan amendment to be in terms of advancing this particular work. So there are folks that like to get it codified and very, very crystal clear. So there's no exceptions, no problems, but you can spend an enormous amount of time working out details that may actually not be important down the road. So just take point number 3 for what it's worth. Moving the ball forward is more important than figuring out some of the details that you may never need down the road. managed care companies, right, can make changes happen with alignment around their key performance indicators. So all of the managed care companies, right, are focused on KPIs, key performance measures, whether it's in quality or access, et cetera. And we found that change is made possible through our managed care organizations, and gaining an understanding of their business and how their business works and their KPIs is very important. And aligning the work, the advocacy work, so to speak, or getting reimbursement for various services in asthma care is important about understanding how they do their work, what their relationship is with the state, and then what the performance measures are that they are really holding themselves accountable for, or really the state is holding them accountable to. So like I think Jillian said this as well, approach managed care companies with a mindset of helping, not demanding a set of covered benefits. So they're looking for opportunities to improve the financial performance of the plan, because that's in the best interest of their customer, which is the state's Medicaid plan, as well as their members. And so thinking about how you can help them rather than, I'd say kind of coming out of like you must do something we've just found that the mindset of helping is a better way to approach the managed care companies. And like Rhode Island, Missouri has in effect switched to a 100% managed care coverage state. So which means that all of our Medicaid business is in effect coordinated by one of 3 managed care companies. If anybody from Missouri is on this call, they'll know it's not quite 100%. There's some special kind of carve-out populations, but generally speaking, for those that are interested in asthma, that's not a material issue. An asthma care clause in the request for proposals can be used as to require coverage or promote asthma-specific KPIs. So a few years ago, when the state was bidding out its managed care contracts for Medicaid, there was a kind of clever idea that came up of making sure that there was terms in the RFP, so to speak, that dealt specifically with asthma, right? So this is the #1 chronic condition of children. The question that we asked ourselves is like, well, wait a minute, what can we do to put up front into the contracts that that various managed care companies would be bidding on key issues that we felt like were important to the state's asthma program. And I think in general, this was not a particularly difficult thing to make happen. And I'm not sure that I'm not sure what the payoff on this will be, but every 3 to 5 years, every state is reevaluating and bidding out various components of its managed care business under its Medicaid program. So consider this as like a possible entry point to getting required coverage in the way that the companies bid on the work that the states are offering to be done. Next slide, please. My third point is around a health home program, which is a per member per month funded care coordination by primary care sites. If your state has a health home program, which is a waiver by Medicaid, pay attention to this and the opportunity that it has for you in terms of getting more resources into asthma care. It's not necessarily going to cover specifically fee-for-service or transaction-based in-home assessments, but what it does do in many states is support community health workers, generally care coordination that occurs out of the clinics, and you can see how that when those resources are put into those sites, that time may be made available to do things like in-home assessments. In Missouri, we were very fortunate, thanks to the work of Peggy Gaddy, our program manager, and others at the Missouri Primary Care Association, which it's our state association of federally qualified health centers, that we got program eligibility for the health home for children with asthma and only asthma. And we've seen an increase in the number of children that are covered under the health home program, which provides additional dollars into the primary care site for the care coordination of those kids. Enrollment in this program enhances clinic and outreach service capacity, and when you increase clinic quality and or outreach service capacity, you do something that we think is important, is you can increase demand for asthma interventions like in-home assessments. So when you increase provider interest in risk identification and referrals for asthma support interventions, you get the byproduct of that is more home environment assessments. So there's sort of on a side note, I would say that you have to think about this whole problem as both a supply and a demand problem. You can build up capacity, you can build up demand for the services, but you have to also have capacity. Or I think the bigger problem that some states may face is they build up the capacity to do home environment assessments, but they haven't paid attention to or focused on how do I drive demand from the provider side on that particular line of service, whether it's self-management, education, or home environment assessments. Okay, last point: return on investment and risk stratification are your friends. In the area of asthma management, ROI is favorable many ways, no matter how you cut it. So the reduction in hospitalization and the reduction in emergency room utilization are high-cost activities, high cost to the health system. And most interventions in-home or other that you're considering are going to have a direct benefit in this particular thing. So don't be afraid of framing your work in financial terms. It's not every condition from public health practice can you do this with, but asthma happens to be one in which the return on investment is relatively short in the number of months or number of years you have to wait to quote-unquote make money with the intervention. And this is important when dealing with health plans or Medicaid who have a relatively short time horizon on how long they'll wait for the benefits to accrue. So but one point here that I think is often overlooked, and I'll raise it, is that risk stratification is critical for allocating services and controlling fear of cost explosion. Julian mentioned this, and I'll kind of tie back to his, of the eligibility they have for their program. I think it's 2 hospitalizations or emergency room visits within a specified period of time. This is a format of risk stratification which allows for Medicaid to know that not every child with asthma, and there are tens and tens of thousands of those in our state, would be eligible for the service, because that, as you can imagine, sort of being a financial officer of a Medicaid program, you can look at and say that could break the bank. So when you're very thoughtful about risk stratification as part of your eligibility criteria for your program, you can control the fear of cost explosion, which is a natural fear that any Medicaid program director should have. It doesn't mean they're evil people when they're trying to say, I have a finite amount of money that I have to be a good steward of, and we can't break the bank. One other thing that I'll just sort of go at as well is we had local data and we had local experience in building the case for our state plan amendment and the other things that we've done, and that was essential for essentially estimating a believable ROI. And getting a believable ROI is what's important and in terms of the meetings and building the partnerships with both the Medicaid program and its affiliated managed care organizations. So next slide, I think, is just a description I kind of included in here. Oh, you can skip that one. That's a cool graphic that we use of describing the work that we do in the Missouri Asthma Program. And then the next slide is really a new initiative with us where we saw an opportunity for getting health plan resources in the hands of school nurses or assisting school nurses in doing things like communicating with physicians, getting same-day or next-day transportation for their kids, making appointments with specialists, and making referrals for self-management or home visit programs. And school nurses in our state are a cornerstone of the work that we do. We have good capacity and wonderful interest and leadership in this particular area. And so one of the focuses of our work is to build that bridge between the schools and the health plans. So thank you very much for your time.
Thank you very much, Eric, and I hope everyone got as much out of that as I did. Eric, that was great. I really loved your point about how we can facilitate the environment in which home visits are more likely to be demanded and to happen by focusing on quality improvement of clinical care, following the NEAP guidelines and getting our populations properly risk stratified is one of the steps to ensuring that we know who needs this care. And I really appreciate your stressing that for us. And thank you.
Yeah, thank you.
And now If you'll advance the slide for me, please. Thank you. Now we're going to hear from Cliff Mitchell, and he's going to share with us some of Marilyn's story. And Cliff's story is such a good story that we're just going to show you that you're hearing to Maryland, and you're going to hear a great storyteller. There's a few things I'd like to encourage you to listen to in Cliff's story. And the first and foremost about all that I encourage you to listen for is the yay. Listen for the woo-hoo in what you're about to hear, and feel it, because it is a great story for all of us, not just for Maryland, not just for Maryland's kids. Listen also for the connection with healthy homes and lead abatement in the rationale and approach that the Maryland team pursued. And finally, listen for the level of effort that is involved in being truly the first to circumnavigate the globe here and to get Medicaid money flowing to community health workers who are delivering in-home care. With that, Cliff Mitchell, my friend, please take it away.
Thanks, Kate. So I will try not to be too loud and try not to do too much woo-hooing because Kate's right. This is, we are at the point where when we were doing our little practice run for this webinar, I made the remark that I felt like a kid in a candy store because I had reached to the point where we are in the process of actually implementing our program. It's very exciting, and I want you all to know that there is not only a light at the end of the tunnel that Eric and Julian were talking about, but at the end of the day, we are just beginning to see the implementation of a program that is, I think for us, a huge leap forward in thinking about asthma and how we do a comprehensive approach at asthma management, just as you've heard from the other two speakers. So I don't have a lot of slides to share with you because I really wanted you to sort of understand the history of how we got here. And some of you may have attended the regional asthma finance meetings that HUD and EPA, the Housing and Urban Development, and EPA put on. We did ours here in Baltimore in 2014 and January of 2014. And out of that grew a discussion between me and our Medicaid director about how we could possibly leverage our Medicaid program to think about doing creative financing for asthma. So Baltimore, like many other jurisdictions, has a long history of lead poisoning and lead exposure as well. And I have always believed, and we have had a strong commitment to a comprehensive and healthy homes approach to being in people's homes. And when we started having this discussion with Medicaid in earnest in 2015, one of the things that we wanted to look at early was how could we think about being in people's homes and not just doing one thing, not just doing asthma, but actually doing more than that. And the genesis of that became a discussion that we were having at the same time around the Children's Health Insurance Program. Now, all of you know that the Children's Health Insurance Program has, like Medicaid, it has direct reimbursement for clinical services, but in addition, it has administrative funds that are available to states at an 88% matching rate that can be used by the states for a variety of purposes, but one of them is to do prevention programming that looks at improving children's health, but not in the context necessarily of a direct clinical service through a provider. Our Medicaid team, including the planning group and the director of Medicaid, and we sat down and thought about how we could leverage those funds and looked at what we were already doing in the state in terms of both asthma and lead abatement, and came up with an idea which we developed over the course of the next year and submitted to CMS in 2016. And the reason I'm saying that is because it took us a long time to get it approved, and there was a lot of back and forth. But in essence, the program was composed of two elements. The first was to use state funds that were already allocated and appropriated for lead abatement in homes and use CHIP funding to match that to create a program with our Department of Housing and Community Development to do lead abatement in homes that exceeded the caps for lead abatement available through other federal or state grant or loan programs. The second was a program that we called the Childhood Lead Poisoning Prevention and Environmental Case Management Program. That's quite a mouthful, but that program was to be a demonstration program in 9 counties in Maryland, 9 of our 24 jurisdictions, and that program would allow local health departments to hire both community health workers and nurse environmental case managers to create a program very similar to the program that you've already heard about in the other states, which would go into homes and conduct 3 to 6 home visits where they would do a comprehensive assessment of those children and look at environmental hazards in the home, particularly related to lead and to asthma, and provide durable goods, again of the sort that Eric talked about, which would include up to and including a HEPA vacuum cleaner, but also buckets, sponges, mops, other things to do dust suppression, mattress covers, pillowcase covers, integrated pest management supplies, and so forth. And that program and the first program to do lead abatement were submitted as proposals to CMS in 2016. In June of 2017, we finally got approval for those programs, and there was a lot of back and forth with CMS on many, many issues. I must say that the credit for our ability to move this program forward goes to our Medicaid planners and our Medicaid team and to the folks at CMS who engaged with us very, very constructively to try to address a whole range of issues that they had, everything from what could we do to make sure that these were not billable services, otherwise under Medicaid or CHIP, to make sure there was no dual billing, to a whole host of other questions that they raised and we all answered satisfactorily. So we now have, as of June 17, an approval for a health services initiative under our state plan amendment for CHIP to do 2 programs. The first uses $500,000 of state funds and a match of $3.67 million to do lead abatement for a total of $4.167 million. And we estimate that that will allow us to abate 70 to 200 additional homes annually for lead. The second uses $360,000 of state money and federal funds of with an 88% match of $2.64 million to give us a total of $3 million to be able to allocate to local health departments, 9 jurisdictions, to provide those services to children with the following, who meet the following criteria. So in order to be eligible for services, we specified that the children had to be, first, under the age of 19. Second, they had to be eligible for or already enrolled in Medicaid or CHIP. And this is very important because one of the commitments we made to CMS is that if the children were not already enrolled in Medicaid or CHIP but were otherwise eligible, we would not only start to provide services to them but also make sure that they were enrolled in Medicaid or CHIP. Then with that as a backdrop, we have actually now gone into our, since the approval, we have started to ramp up the program and are now in the process of enrolling children. And I can take a few minutes to talk about that part of it because getting the approval was in some parts not the easy part by any means, but we've come up with a whole host of things that we've had to do since that time. One is CMS has a bunch of metrics that they want us to measure about how well the program is going. And so we had to design instruments with Medicaid that would collect efforts of the local health departments, how many kids were recruited, how many we were able to see, so forth and so on. There's a whole invoicing process because this program operates in a way that is somewhat unique for the health department because unlike other federal funded programs that go to local health departments, this one has to be invoiced and then the local health department's reimbursed for the efforts that they make under the program. And we had to devise an entire invoicing system and a unique way of ensuring that that invoicing system met all the requirements of CMS, our fiscal people, the local health department fiscal people, and that's been an ongoing discussion in and of itself, especially because local health departments have, particularly for these programs, this is a new experience for them doing this kind of invoicing. Third, we had to train community health workers. Maryland does not have a licensure for community health workers, so in partnership with the Green and Healthy Homes Initiative that you've already heard about, which is a terrific collaboration for us, they have trained community health workers in each of the 9 jurisdictions. And all of those are now operating and moving forward. They've hired or are in the process of hiring. They are already going out to see kids, and it's really, really exciting to see. We estimate that we will be able to see somewhere between 1,000 to 2,000 kids a year, 1,200 to 2,000 kids a year with the funds available to this program. Our local health departments are very excited about this. I have been going around doing grand rounds with healthcare providers, and the pediatric community is very excited about this because they see an opportunity working with the local health departments to do something that they've always wanted to do, which is to have an ability to get into the home and see conditions in the home. And so this really is, in some ways, an extension of, for those of you who know the patient-centered medical home, this is almost a community-centered medical home where, as a part of this process, we share information from the home visits back with the providers, and we also ensure, for example, that all of these children have asthma action plans. If they have not got an asthma action plan, we'll be contacting the primary care provider and asking them if they could help us by creating an asthma action plan. It's one of the metrics that CMS also wants to see. And at the end of the day, I think that all of the people who are involved in this are really excited because we see it as an opportunity to have ongoing support and resources to create for children with asthma a seamless medical communication system and intervention that partners the local health departments, primary care providers, school nurses, pharmacists, everybody involved in the care of the child. And we see ourselves very much as a part of that system where this has provided us with an opportunity in the state to advance asthma care and improve health outcomes for these kids. We, like others, are targeting for enrollment children with moderate to severe persistent asthma. That's actually written into our CMS agreement. And our Medicaid folks were able to do a look back for 2 years from 2015 to 2017 and identify children under the age of 6 with at least 2 emergency department visits or 1 hospitalization, and for children over 6, 4 ED visits or a hospitalization within the look-back period. And we have provided those lists of children to each of the participating 9 local health departments so that they are able to contact those children and use that as their starter or finder pool of kids involved. Just to give you a scope, we estimate that there are probably more than 5,500 children with asthma who meet those criteria for the last 2 years amongst the 9 participating jurisdictions. So what I wanted to leave you with then is it's really an exciting time for us. I have to give a huge amount of credit to the people I've mentioned, our partners in local health departments, the Department of Housing and Community Development, our Medicaid partners particularly, with whom we could never have done this. And it's a real slog. Let me just tell you, I've had a great deal of fun and challenge devising home visit forms for people with both either lead or asthma or both. And our staff, I think, are very excited to be going out there. And we are looking forward to sharing the results of all of this with you as we move forward. So, Kate, I'll turn it back to you and just say that the woo-hoo part of this for me is, as a physician and as somebody who's been involved in this work for quite some time, this is really an exciting moment because I think it really represents an opportunity to improve asthma care nationally, locally, and in communities that, particularly in Maryland, as everywhere, we can really begin to address some of the health disparities that are at the root of some of the challenges that our children with asthma face. So, Kate, back to you.
Thank you, Cliff. Thank you for the inspiration, the motivation, and the information. And let's all go get every state in the nation to have what Maryland's got. May I ask, Erin, can I ask you to advance the slide for me, please? I just have one little slide to share here, and then I'll turn it over to Sheila, who will get us into the discussion forum for all of you who would like a chance to interact with our speakers. So we said at the beginning that we would provide some resources to give you ideas of where you could get some help. I want to let you know you are not alone here. There are additional available resources to support you. The National Center for Healthy Housing has an online e-learning course. It's 10 short, self-paced courses. It can really help leaders who are looking to figure out how to move their community systems forward. It's a great place to get some support and help in figuring out how to do that in your community. And in addition, for the next 10 weeks, the National Center for Healthy Housing and several of our expert colleagues will offer open office hours where they will share feedback and advice. They can provide some mentorship. They'll share with you successful or not examples of what they know has happened in communities that may look like yours. So please make sure to avail yourself of these resources if you think you could get some help there. Open office hours through the end of the month, or through the end of June, excuse me. And now with that, I want to thank our speakers so much for their time and their preparation and just beautiful participation today. And thank you, audience. And Sheila, thank you so much to EPA for hosting us all. Let me turn it back over to you now, and you can help us get into the discussion forum.
Thank you so much. This concludes our presentation portion of the webinar. Thank you, Kate Hastings, for masterfully moderating the webinar panel presentation. A heartfelt thanks to the 3 presenters for sharing their stories, time, and insights. And a huge, huge thanks to all of you who participated. We're glad you could join us and hope the session was useful and valuable for you.